What excites you about the neuromuscular community in that aspect specifically?
Well, I think the main thing is the human interactions that occur at a meeting like this and then throughout the year. Fundamentally, human disease is something that demands that we work together as human beings. We don't solve problems as individuals in areas like this. It takes teamwork of different kinds of people, the scientists, the clinicians, the families, the patients. And when I say clinicians, I don't just mean doctors, I mean nurses and physical therapists and respiratory therapists, et cetera. So this is all really important and a key feature of this particular organization and community. Having said all that, we still are dependent on the funding for high quality science. And a key area where I think people are taking advantage of this now in this community is that we have more and more technologies that can be platforms. I mean, you mentioned that we have many different neuromuscular diseases. Many of them have similarities in that they're genetically based, and so the technologies that allow for gene editing, for example, if someone working on a therapy for one disease figures out how to do gene editing better, that accrues to the benefit of all the others. So all the more reason to be communicating as frequently as possible about this.
Obviously there is more therapeutics that are starting to come into the fold, including things like gene therapy, which has a lot of conversations around it, and the discussions between patients and clinicians are going to be very, very important over the next couple of years. So as more drugs continue to come into the fold for these disorders, what will the clinical and patient communities need to keep in mind? Talk a lot about any considerations with these new therapeutics coming on the rise.
Well, there's so many considerations. Just to mention a couple that are on my mind right now, we don't have enough clinicians. If you look at the explosion of therapeutic options for people, these are not things that happen in a vacuum. You need an interaction between a patient and a clinician to make these decisions. And then if a therapy is administered, they're not so simple. There's sometimes really serious risk in these treatments. So we got to train more clinicians and make it so their lives are positive. They're under great duress right now, what's been called moral injury. They don't have the time to do the things they need to do now, and then we're going to add more exciting possible therapies, which is a great thing. But we got to have enough clinicians to do the work. Second thing is, just by the nature of these issues, we won't know everything that we'd like to know at the time the treatments are on the market, when they're available. And so we're going to have a systematic way of learning in the post-market phase with these interventions. It means that people need to volunteer to work together. MDA has its clinical care centers. Hopefully people will volunteer their electronic health records and digital information they can collect so they can be followed over time to learn. I mean, just one example that I've been talking with people about recently in common diseases, very pertinent to the situation here. Let's say we have what might be considered a monogenic disease. There's one mutation or one gene which is responsible for the disease. And then we edit that gene. What we don't know is how all the other genes are going to interact with that newly created genome. And that could evolve over time. It may be years before we see what happens. And like so many things in medicine, it could be either really, really good or it could be a problem that needs to be dealt with. So we need a detection system that can figure that out. In the short term, there'll just be very hard decisions to make in the face of uncertainty. It's going to be really important for the advocates to work with the clinical and the financial community to come up with a way of funding these treatments. Let's say we develop effective treatments for 1,000 rare diseases over the next year. If it's going to be 1 to 2 million per dose, that's not going to be viable. We're going to need some better way using, as I said, platforms and working together to solve these problems.